Welcome back to FMGE Recall Rush. Today, we have some crucial ophthalmology questions from the previous years. You must answer each question within 5 seconds, which shall be followed by a brief explanation to enhance your knowledge. Let's get started with the first question.
Question 1. The SAFE strategy given by WHO forms the mainstay of the management of trachoma. What does the S in this acronym represent? Here are the options. A. Surgery, B. Symptom, C. Spectacles, D. Symbol. And the correct option is A. Surgery. Here is the explanation.
What is the way we are treating this is SAFE strategy, isn't it? So please remember, what is SAFE strategy? This has been a repeated question recently asked. We all know it stands for surgery. Which surgery? For trichiasis, isn't it? For acronym and trichiasis, whatever surgery you're doing, generally we will say preferably, if both are given, you should answer trichiasis. Okay, so this surgery generally what we go for is bilamellar tarsal rotation. We don't need to go into too many details here. Let's remember this. The surgery is primarily for trichiasis and acronym. It's almost the same thing because acronym is and they go together generally, right? So there was only one question where they were given as choices, then we had to answer trichiasis. What is A for? We all know antibiotics. So what are the antibiotics I can give? I can go for either option. I can go for azithromycin or I can go for tetracycline. Now what is the treatment of choice? Definitely it has to be azithromycin, right? So azithromycin 20 milligrams per kg in children. You have to remember, and in adults 1 gram. Isn't it? We know this. So this is important. And why not tetracycline? So you have to understand here, 1% tetracycline is considered less effective than oral azithro. Very, very important. And second important thing is, it is very cumbersome. Compliance is very poor because you have to keep putting ointment. And also tetracycline has its own disadvantages. In children, if you are going to give, it can lead to different problems like tooth staining and so on. Generally, it is contraindicated in children, right? You know more about details and side effects of tetracycline. But still, they have asked you if you are giving, what is the percentage? Make a Q and write down it is 1% ointment. But I would still prefer azithromycin, which is more effective, easier to use, and more safer. F stands for what? Facial hygiene, and E is environmental cleanliness, right? So facial hygiene and environmental cleanliness. That was about your SAFE strategy, and this is how you should be ideally treating a trachoma.
Question 2. A 3-year-old child is having amblyopia in the right eye. What is the preferred treatment for this child? Here are the options. A. Observation. B. Spectacles refraction with near addition. C. Occlusion therapy. D. Radial keratotomy. And the correct option is C. Occlusion therapy. Here is the explanation.
What is the treatment of choice of amblyopia? And even today, the majority of the time what we are doing is occlusion. What occlusion? Which eye? This is important. So occlusion of normal eye, please. Okay. Why? Because the other eye is lazy now. You want to stimulate it, activate the fovea. Therefore, occlusion of the normal eye. But don't you think if you occlude that normal eye, this can also become lazy? That is why we have some definite hours of occlusion. It should be any time between 4 to 6 hours in a day is ideal. And also we have to understand that as the age is going to increase, it becomes difficult to treat the amblyopia. Okay, so keep this in mind. So according to the age also there's a criteria that if your patient is 1 year of age, you can occlude for 1 day, open for 1 day. 2 years of age, 2 days of occlusion, 1 day you can open. 3 years, 3:1, right? 4 years, it is 4:1. 5, it is 5:1. And 6 years, it is 6:1. Right? Generally, what is the age when the amblyopia treatment is effective? See, if you ask me, most ideal it is 6, but generally we answer up to 8 years. So if they ask you this question, so amblyopia treatment, if of any use, you can say is effective till, it is done till 8 years, but ideally it is most effective till 6 years of age. Most effective till 6 years of age. Please remember this. Right? But we do it till 8 years, no doubt. Right? It may be an exception and patient may respond, so we can do it till 8 years. Right? Okay. So once you know this, we next talk about, is there any other way of occlude? How do you occlude? We put a patch. Let us have a look. See. So this is the amblyopia mein. This is crowding phenomenon. The same letter can be seen properly when it is presented separately. So this is the patch which you are using as an occlusion. Is there any other way of occlusion? The other way is called penalization. What is penalization? When we use atropine as a means of occlusion, we call it penalization. So atropine, generally what we do in a practice, after the occlusion and if both the vision of both eyes have equalized, don't stop it immediately, it can again go back. So we put the patient on weekly atropine. Okay, so atropine can be another means of, why? Because when you're paralyzing the ciliary muscles, the near focus is not good, near vision, everything will be blurred, and it is almost like occlusion only. Okay, so that is another method of occlusion.
Question 3. A patient with sarcoidosis shows Koeppe's nodules on ophthalmologic examination. Where are these seen? Here are the options. A. Cornea, B. Conjunctiva, C. Iris, D. Retina. And the correct option is C. Iris. Here is the explanation.
Let's come to the next finding here is nodules. Nodules on the iris. Either it is at the pupillary border. What do you call this? Koeppes. Koeppes can be present in both granulomatous and non-granulomatous inflammation.
Question 4. A patient presents with a hard painless nodule on the upper eyelid. It was observed to be growing outwards, away from the lid margin. What could be the most probable diagnosis here? Here are the options. A. Sty, B. Entropion, C. Chalazion, D. Blepharitis. And the correct option is C. Chalazion. Here is the explanation.
Chalazion. On the same diagram I am putting, this time it's a painless swelling on the lid margin. So the painless swelling on the lid, not margin, lid, on the tarsal plate. This painless swelling is chalazion. Repeated question, what is chalazion? So how do you define chalazion? They have asked you repeatedly. We learn chalazion is, make two cues, lipogranulomatous inflammation of meibomian gland. It's a lipogranulomatous inflammation of meibomian glands. Okay, and it will present as painless swelling on the lid. This we have already done. How do you manage this? Number 1, incision and curettage. Don't say drainage because it's organized secretions. So curettage. It's not a liquid pus. Even this was asked in the exam. Incision, drainage or incision, curettage. Secondly, whenever you are giving an incision and taking out in a chalazion with a chalazion clamp, pivot, put the clamp. Very, very important point, all of you. It should always be a vertical incision. Why? Because the ducts of the meibomian glands are all vertical. So if I put horizontal incision, in that case, we will damage the ducts. So we go for vertical incision.
Question 5. A 27-year-old male patient suffers trauma to his eye with vegetative matter. He now presents with a corneal ulcer alongside hypopyon and satellite lesions. He reports mild pain with photophobia and redness. What is the most likely diagnosis? Here are the options. A. Fungal keratitis, B. Acanthamoeba keratitis, C. Viral keratitis, D. Bacterial keratitis. And the correct option is A. Fungal keratitis. Here is the explanation.
And what is this ulcer? Look at this one. This has a more rough look, isn't it? So when the ulcer has a dry, rough look, it is a fungal ulcer we are talking about. So dry, rough ulcer. Fungal ulcer, we can say it is keratomycosis. So our next heading will be fungal keratitis, also called keratomycosis. Which is the fungus which infects the cornea? So broadly, first of all, you all should have an idea. Two types of fungal infection. One group is called yeasts, right? So name that you have to know here, most common is, of course, Candida albicans. This infection is more in the temperate regions and colder regions. And the second, of course, is your filamentous fungi. Filamentous fungi, this is actually septate and non-pigmented. This septate fungi infects the cornea in tropical countries, and main two names that you have to know is Aspergillus and Fusarium. So all of you, once you know these two group of fungi, we are not talking in too much detail, but the things that we are supposed to know at this point. So they will ask you the first question, keratomycosis, it's a very important topic. Which is the most common fungus infecting cornea? Which is the most common fungus infecting cornea? It will be Aspergillus, you should know the full name, fumigatus. It is Aspergillus fumigatus, right? Okay. Then they will ask you, if this option is not given, what is the next best option I will mark? Fusarium. So these are the two filamentous fungi which tend to be causing infection in the cornea. Let us talk a little bit more here. What is the most common infection, fungal infection for lids? Now our answer will be Candida albicans. And if I ask you for what is the most common fungal infection for endophthalmitis, what you will answer? Endophthalmitis. Again our answer is, so what is the most common? Again your answer is Candida. Okay, and if you are asked most common cause of orbital cellulitis here, orbital cellulitis, mucormycosis. You all know mucormycosis? It has been an important topic for you now. Lot of cases of mucormycosis after COVID. Why? Because the steroids were just used thoughtlessly, right? So I hope you all know black fungus doesn't mean that the fungus is black. It is causing necrosis in the tissue, and therefore we call it black fungus. We'll talk about it in the orbit chapter also. So just know that the most common cause, fungal cause of orbital cellulitis, we will answer mucormycosis. Okay, so once we know which is the most common fungus infecting the cornea, and of course the infection, as we have learnt, is generally, this is a repeated question. Why will you get a fungal keratitis? Trauma by a vegetative matter. Please remember, trauma by vegetative matter. Like getting hurt by a leaf or a twig. That is why it is more common in agricultural groups, right? Okay. So please don't forget organic matter or vegetative matter. Otherwise, of course, any cause of low immunity can be a predisposition towards fungal infection. This we all know, immunocompromised patients. Right. So once we know this, the next important question, so we have started with Qs only here. Compared to bacterial keratitis, signs are more or symptoms are more? This is an important question asked. So you will say signs are more than symptoms. We are comparing with what? Be clear, bacterial keratitis. What do we mean by when we say this? Suppose a patient is entering my OPD, he is not shouting out of pain. He comes and sits in front of my slit lamp, and I observe a very big, examine him, and I see a very big ulcer on his cornea. It cannot be bacterial, it has to be fungal, right? Bacterial, even this much of the ulcer, and the patient is shouting out of pain. Okay, so this is what we mean by that the signs are more than symptoms, correct? Okay, so once we know these important points, how will this patient present? Life is simple. Again, those 5 features, this is what pain, redness, photophobia, blepharospasm, discharge, blurred vision, everything will be there. But of course, compared to signs, the symptoms are less, right? Okay. Then we come to on examination. What do you get? Let's draw. That's what we do when we learn on examination. My style, you will draw it. First, you will draw this and write here. that you get a dry, rough ulcer. First important point. Which was the bacteria which had the same appearance? We just learned nocardia. Okay. Then, second, of course, it's factual, you have to learn it. It has projecting ends, these are hyphae. Next important point. Third point, the ulcer, the hypopyon here is unsterile. What do you mean by this? Fungi can penetrate the whole cornea and enter into the anterior chamber. That is why we are saying unsterile hypopyon. Got it? So what do you mean by unsterile? Achha, don't get confused with these are the bacteria which can penetrate the intact bacteria which can penetrate intact epithelium. We are not talking about the whole cornea. Just penetrating the intact epithelium and infecting the cornea is one thing, and going into the anterior chamber is another thing. So what is fungi doing? It can go into the anterior chamber and therefore the hypopyon is unsterile. We can see the fungi. I think it's clear now. Then of course a double Q. This is also Q. I hope you know this. And then comes a double Q, and that is your satellite nodules. What are these? Main lesion ke alawa, apart from the main lesions, you are getting satellite lesions or nodules. These are lesions away from the main ulcer. Right? So this is why? Because it is not only infective in nature, these satellite nodules are both infective and also there is an immune response. What else I can see? I can see a Wesley ring, immune ring called Wesley ring. So again the immune cells are accumulating and forming a ring out there around the ulcer area or somewhere on the cornea. So this is what is called Wesley's ring. Now what is this exactly? Is it only a feature of fungal? No. Please remember, it's an immune ring, host response towards the infection, correct? So it can be seen in fungal, in few bacterial also, and in viral also. But if they ask you to choose one, we will always give priority to fungal keratitis, right? So these are the points to remember for your fungal keratitis. What are the findings?
Question 6. A 61-year-old university professor presents with a loss of vision in his left eye. He describes the sensation as a curtain being drawn over his affected eye. In addition, 7 days ago the patient noticed what he described as flashing lights and floaters. He gives a history of having cataract surgery in the same eye 3 weeks ago. A B-scan image of his left eye is shown below. What could be his condition? Here are the options. A. Glaucoma. B. Retinal tumor. C. Retinal detachment. D. Corneal ulcer. And the correct option is C. Retinal detachment. Here is the explanation.
Let's talk about retinal detachment. What did we discuss? Retinal detachment is separation of retinal pigment epithelium from neurosensory retina. So let us define it. It is the separation of retinal pigment epithelium from neurosensory retina. Right? Simple? Okay. What are the types of retinal detachment? Types of retinal detachment, there are 3 types. One is your rhegmatogenous. Second, write down tractional retinal detachment. And third is exudative. When you say rhegmatogenous, one by one, first is rhegmatogenous. Rhegmatogenous, what do you mean by that? So rhegma means break, okay? So rhegma is break in the retina. So this break in the retina, so we are discussing how this is happening, can either be a tear or a hole. Okay, so this is how it is created. So when you say tear, this is due to traction, right? Tear is due to traction, and as a rule it is always horseshoe shaped. Tear is horseshoe shaped. Whereas when you say hole, any degenerative change can degenerate and lead to hole formation. So hole is after degeneration, right? What can be the most common cause of traction? So in old age, when the vitreous collapses anteriorly, what do you call that? Posterior vitreous detachment. So most common cause of this traction leading to this regma formation is PVD. This is your posterior vitreous detachment. Right? Okay. Then they have asked you another question. Which are the degenerations which are prone to and to lead to hole formation? So which are the degenerations which are dangerous and can lead to hole formation? We are going to learn two. One is lattice degeneration. These names are all based on the morphological appearance. So lattice degeneration and snail track degeneration. Lattice and snail track degeneration. Right? Okay. So once we know this, second was so that is regma. So what is happening? Can we think together? Any kind of break in the continuity of the retina, go to your first diagram, the water is going to enter from the vitreous into the subretinal space, and when it enters the subretinal space, that leads to, so when the water reaches the subretinal space, that will again cause retinal detachment. This is your regmatogenous retinal detachment. Okay. And how do you get an exudative retinal detachment? Exudative means there is some exudation. What can be the cause of exudative? Exudative means if this is the retinal pigment epithelium, there is some exudation from the choroid which is going into this subretinal space, and this is causing retinal detachment. So this is the neurosensory retina. I hope you remember this diagram, right? So this is any cause in the choroid which is causing accumulation of fluid in this subretinal space and leading to retinal detachment is exudative retinal detachment, right? So exudative, we can think of few causes of exudative. It could be just an inflammatory cause, like inflammatory cause, for example, in cases of scleritis, right? Posterior scleritis, that could be one cause, right? It could even be due to vascular cause like CSR, or there is any neoplasm, tumor, neovascularization. All this can lead to exudative. And also we should also keep in mind some seismic causes. Seismic cause you can note down is pregnancy-induced hypertension, very important for you all, right? Our renal hypertension or PIH. Just remember these two. Okay, so this could be systemic. So just remember, if I want you to put it in a crux, any neovascularization, any tumor, any pathology in the choroid which percolates into the subretinal space and causes the retinal detachment is what? Exudative retinal detachment. Okay. Now we talk about fractional. Fractional we all know so well. When there is retinitis proliferans, that is called neovascularization in the vitreous. The new vessels with the fibrous tissue will contract, pull the retina, leading to tractional. We have done this, so that is your tractional. Now, which is the most common is your exam question. Let us note down. Most common type of RD is regmatogenous, because even tractional can lead to regmatogenous, right? Most common type of retinal detachment you will answer is regmatogenous. Okay, so what are the clinical features if this patient is suffering from retinal detachment? Let us think ourselves what will happen. Do you realize, first thing is your diminution of vision, especially if the central retina is involved, definitely. If it is the peripheral retina, what are we getting? Visual field defects. Think with me. If your superior retina is detached, what type of defect are you going to get? It is inferior field defect, and vice versa. What else I can get when you talk about retinal detachment? Especially in case of, so this is overall I am giving you the picture, but especially for regmatogenous, it is said a curtain is falling in front of the eye. Okay, so curtain falling in front of eyes, especially for, is the history given by the patient, and this is more in relation to the regmatogenous. So something like this. So the patient is reading and it can feel this diminution, as if the curtain is coming in front of the eye. Okay. What are the other features apart from this? The patient will complain of floaters. Everybody knows what is floaters? Floaters are opacities in the vitreous cavity. Okay, opacities in vitreous cavity. So the patient complains that something is moving in front of my eye. These are nothing but floaters. Then next is your photopsia. What is photopsia? Photopsia is flash of light seen by the patient. In the field, there is a flash of light, either at the peripheral field or somewhere in the center. Generally, it is at the periphery actually. This flash of light is photopsia. Why is it happening? It is due to, write down, traction on rods and cones. It is due to traction on rods and cones. On the photoreceptors, you get photopsia. And what else? Gray reflex. What is the actual color of retina? It is not red. It looks red because of choroid, because choroid is very vascular. Actual color of the retina is grayish one. So when it is detached, we can appreciate that, and this is what is called gray reflex when the redness is less. Okay. Then we talk about on examination findings. On examination, what are the things you have to keep in mind? We first take into account rhegmatogenous. How does it look like? What are the points we have to remember for rhegmatogenous retinal detachment? Since it's a rhegmatogenous retinal detachment, first is it will have a, when you look at the retina, it has a corrugated appearance. We describe it as corrugated appearance. A very slight mobility which is called undulating. Okay. You will get both floaters are present because of the opacity of these dispersion of pigments due to the retinal break formation. The pigment can disperse into the vitreous, leading to floaters. So floaters is one feature. Second, write down, you will get photopsia also in this case. This is more of a symptom than a sign, of course. I'm just mentioning it here. Right? And very important, too many pigments in the vitreous. This is what is called tobacco dust or Schaffer's sign. It's an exam question, all of you. What is Schaffer's sign? Pigment dispersed in the vitreous cavity. Okay, so make a cue here. This is also called tobacco dust. It is a sure sign that there is a retinal break. If you are not able to locate a retinal break, please do more of the indirect ophthalmoscopy to find out where the break is. Right? So, this is what is Schaffer's sign, which is a sure shot indication that we have a retinal break. And here see, this is how you will see a retinal detachment. You see the line is separating from the neurosensory retina, separating from RP. So this is what is retinal detachment, and here I can see, can you see the peaking here? That's why you are saying that this is a vitreoretinal traction.
Question 7. Which is the most common cause of preventable childhood blindness in India? Here are the options. A. Refractive error. B. Vitamin A deficiency. C. Retinopathy of prematurity. D. Injuries. And the correct option is B. Vitamin A deficiency. Here is the explanation.
First of all is most common cause of blindness in India. Tell me. Yes, it is cataract. Right? Then next question. They can also ask you most common cause of preventable blindness in India. Again, please remember that cataract cannot be prevented, but the blindness due to cataract can be prevented. So, if cataract is in the option, our answer will be cataract. Clear hai? If this is not in the option, then the next best option would be trachoma. But first we will answer cataract. Okay, next question. Next question is most common cause of childhood blindness in India. What will you answer now? We will answer vitamin A deficiency. Okay?
Question 8. An industrial worker was admitted to the hospital after an eye injury sustained while cutting stone with a hammer and iron chisel. A foreign body was suspected to be impacted in his eye. Which of the following is the best investigation for foreign body localization? Here are the options. A. MRI, B. CT, C. X-ray, D. B-mode scan. And the correct option is B. CT. Here is the explanation.
Talking about the intraocular foreign body, any foreign body which goes intraocular will have three effects. Can we write together, please? What are the three effects? Write down mechanical effect. Mechanical effect, like for example, cataract can happen due to any capsular injury, or vitreous liquefaction can happen, retinal hemorrhage, retinal tear. As we just saw, it can even lead to different types of retinal detachments, right? So mechanical effects because of that foreign body inside. Second, it can lead to infection. Therefore, any intraocular foreign body, we want to give prophylactic intravitreal antibiotic injections. And third, of course, it's toxic effects. So these are the three effects: mechanical, infection, and toxic effect. If we talk about and divide the types of intraocular foreign body, we will write like this. It can be either inert or reactive. Just note down what are the inert foreign bodies. It can be glass, wood, plastic, rubber. You should know this. You should have an idea. These are inert foreign bodies in the eye: gold, silver, platinum. Reactive can be organic. Inorganic, what we have to learn? We have to learn about siderosis and calcosis. Right? Okay. So these are the different types of intraocular foreign body possible. We know what are the three effects it can cause. So we can see this is one intraocular foreign body here. This one is on the retina, in the posterior segment, in the vitreous. So how do you work up if you get a case of an intraocular foreign body? So when you get a case of, we have to do a detailed examination to know, and also not only detail anterior segment, posterior segment, we have to also do the gonioscopy, and of course for posterior segment we are doing fundoscopy. After this detailed examination that you have done, what is the investigation of choice? This was a recent question of your exam. So it has to be CT scan, never MRI. Okay, why? Because it is not good if it is a metallic or metallic foreign body, right? So generally magnetic ho sakta hai na, if the foreign body is magnetic, this is not recommended. So don't do MRI, we will always go for, you will say we will go for CT scan as the investigation of choice.
Question 9. An ophthalmology resident is evaluating an elderly patient with Bell's palsy who complained of dry eye, redness, and irritation. Slit lamp shows multiple punctate epithelial erosions in the cornea. Which of the following is used to manage this condition? Here are the options. A. Tarsorrhaphy, B. Contact lens, C. Corneal replacement, D. LASIK. And the correct option is A. Tarsorrhaphy. Here is the explanation.
Coming to paralytic ectropion, paralytic means part of facial nerve palsy. So again you have to treat accordingly to see that there is no exposure keratopathy as well. So artificial tears and ointments, and along with that this ectropion, if you can go for, is your tarsorrhaphy. You can treat with, if poor Bell's phenomenon, tarsorrhaphy I told you, where we are joining the two lids to close the eye. And permanent treatment again can be medial canthoplasty, or sometimes we can use silicone rings.
Question 10. Microaneurysm are seen in which of the following diseases? Here are the options. A. Retinal detachment, B. Diabetic retinopathy, C. Uveitis, D. Glaucoma. And the correct option is B. Diabetic retinopathy. Here is the explanation.
So if we have understood this much, first thing is, what is the first, this is exam question again, what is the first sign of diabetic retinopathy? We should answer microaneurysms. It is microaneurysms. There is a recently asked question, which layer the microaneurysm is present. So we have to answer nerve fiber layer. We will not answer inner nuclear, we will answer nerve fiber layer.
Question 11. Where is the lesion that produces the visual field defect shown in the image? Here are the options. A. Craniopharyngioma, B. Meningioma, C. Pituitary adenoma, D. Temporal lobe lesion. And the correct option is D. Temporal lobe lesion. Here is the explanation.
So now common sense. If there is any problem, temporal lobe lesion hai, any trauma or any reason of temporal, so any lesion in the temporal lobe, which fibers are gone? Inferior. What will be the field defect? Superior. Now it is only some fibers which are affected, so it is never a hemianopia, it's always a quadrantopia. So if suppose I say left temporal lobe lesion, if we take an example of left temporal lobe lesion, do we realize this, that this is the left eye field, this is the right? We are going to get superior quadrantopia because inferior fibers involved. Left-sided lesion hai to right-sided superior quadrantopia. I am going to draw something like this. Okay, so this is right-sided superior quadrantopia. To the right side, quadrantopia. Okay. Which is also called, exam question, pie in sky. This field defect is also called pie in sky. If you all are not clear, if it is a right temporal lobe lesion, right-sided lesion will lead to what? Right-sided lesion. Left-sided superior means something like this. Now it is clear? It is left-sided superior quadrant, but it is always a superior quadrantopia. So it is pie in sky of the left side, left-sided superior quadrantopia, because now the lesion is of the right-sided temporal lobe lesion. It is always opposite, I have taught you.
Question 12. In which of the following conditions there is ipsilateral third nerve palsy with contralateral hemiplegia and facial palsy of the upper motor neuron? Here are the options. A. Weber syndrome. B. Terson syndrome. C. Millard-Gubler syndrome. D. Fowl's syndrome. And the correct option is A. Weber syndrome. Here is the explanation.
So first is your Weber's syndrome. So what is Weber's syndrome? Due to the involvement of cerebral peduncle. Weber's syndrome is third nerve palsy with contralateral hemiplegia. Okay. So this is what is Weber's. If you have difficulty in learning, I am giving you a tip. W for Weber's, W for weakness. So it is contralateral hemiplegia. That is the tip. They have asked you, it's exam question. Second, we will learn Benedict syndrome. So now hemiplegia, why it is happening? Involvement of cerebral peduncle. Can you see this? This is your cerebral peduncle. So there is involvement of the cerebral peduncle at this level when this fascicle, that is third nerve, this is the third nerve nucleus, this is the third nerve, and this is your red nucleus.
Question 13. True about pterygium. Here are the options. A. Inflammation of cornea. B. Fatty deposition of sclera. C. Conjunctival invasion making a flap over cornea. D. Dead epithelial debris accumulation. And the correct option is C. Conjunctival invasion making a flap over cornea. Here is the explanation.
Conjunctival degenerations, if we talk about, one degenerative condition very important at your level is pterygium. Okay, make the diagram. I know everybody knows what is pterygium. So look at this. We all know this triangular fibrovascular subepithelial ingrowth, isn't it? So this is the fibrovascular subepithelial ingrowth. It is a subepithelial ingrowth of bulbar conjunctiva over the limbus. Can we write it? What is pterygium? Write down here. I am writing for you. Please make the diagram also. Draw it on your copy like this. And now write the diagram and write the definition. Write down. It is a triangular fibrovascular subepithelial ingrowth of bulbar conjunctiva. Over the limbus. Okay? Over the limbus.
Question 14. The corneal endothelium is a single layer of cells on the posterior surface of the cornea. An estimate of this endothelial cell density and function can be done by specular microscopy. This corneal endothelium is derived from, here are the options. A. Neuroectoderm. B. Neural crest cells. C. Mesoderm. D. Surface ectoderm. And the correct option is B. Neural crest cells. Here is the explanation.
Neural crest. The neural crest has a neural part and a mesenchymal part. Neural part, generally the myelin sheath develops from this part, right? So, mainly, so when you say the neural part, this hasn't been asked to you, but we will just put it here. This is mainly the myelin sheath we are talking about. We all know myelin sheath is derived from oligodendrocytes when we talk about central nervous system and from Schwann cells in the peripheral nervous system. Okay, so myelin sheath, this is derived from here. We can also learn ciliary ganglion. We have talked so much about ciliary ganglion. Talking about the mesenchymal part of the neural crest. The mesenchymal part, we will learn here how to learn this? All coverings. Let us think of coverings. Outside, sclera. So first sclera, note down here, except temporal part. All the sclera except temporal part. Okay, what next? Choroid. Okay, we can note down choroid. What next? Cornea. What about cornea after sclera? So corneal stroma and corneal endothelium. Both are derived from neural crest. Corneal stroma, corneal endothelium. Okay. Then next we will learn ciliary muscles are derived from neural crest. Trabecular meshwork is derived from neural crest. Right? Stroma of not only choroid but iris and ciliary body. So stroma of both iris, ciliary body and choroid, they are derived from neural crest. Okay? And also the orbital bones.
Question 15. Russet cataract is seen after. Here are the options. A. Blunt trauma to eye. B. Copper foreign body in eye. C. Penetrating injury to eye. D. Infection. And the correct option is A. Blunt trauma to eye. Here is the explanation.
Traumatic cataract. So our next heading will be traumatic cataract. When you say traumatic cataract, there are three broad headings we have to take care of. What are the types of trauma or injury in the eye? Perforating, right, or penetrating injury. Second is your blunt trauma, which is called concussion injury. And one more thing that needs a mention is your electric cataract. So, perforating injuries, if this perforating object is hitting the lens, right, then definitely it will lead to cataract. Second, I said blunt trauma. Lot of questions, very important, blunt trauma. Also called concussion injury, right? Concussion injury. Let's make a cue here, all of you. 2 cues here, very important. So there are 3 main things that we have to keep in mind regarding blunt trauma, and all 3 are exam question. Let's put the cues. So first is your which type of cataract? It is called rosette shaped cataract. Okay, it is called rosette shaped cataract. Another question. Rosette shape involves which part of the lens? Mainly posterior cortex. It involves posterior cortex.
Question 16. A patient with a history of fall on symmetrical surfaces presents with ophthalmos diplopia on upward gaze and loss of sensitivity over cheek. True statement about this is? Here are the options. A. Maxillary fracture. B. It is a blowout fracture. C. Zygomatic bone is most likely injured. D. Frontal bone fracture. And the correct option is B. It is a blowout fracture. Here is the explanation.
Let's write the points here. Can you see here? This patient has got a blunt trauma in the right eye, because of which, what are the things or features we can see here? So first of all, what are blowout fractures? Number 1 point, fracture flow due to blunt trauma. I have already talked about that the weakest part is posteromedial. And why there is a fracture of the floor? Write down the mechanism is buckling effect. Due to the, so when there is a blunt trauma, there is a buckling effect in the floor which leads to its fracture. Okay. What further we will write here, that any blowout fracture can be pure or impure. Pure we say when infraorbital rim is not involved. So when rim not involved, then we call it pure. Impure means infraorbital rim is involved. Infraorbital rim is involved. Then this is your impure. Okay. Now we talk about features. Think yourself, we are going to learn in my style, outside to in. If there is a blunt trauma, first black eye, isn't it? We call it periocular ecchymosis. So first would be periocular ecchymosis. That is also called black eye. Now I want to point out here, this is not panda eye or raccoon eyes. That is seen in fracture base of skull, right? Roof fractures, not in floor fractures. Secondly, what you will see, think again, decreased sensation on the affected cheek, the side, of course, any side wherever the trauma is. So decreased sensation on the cheek. Okay. Why it is happening? This is due to damage to infraorbital nerve. Damage to the infraorbital nerve. Now, how will I know how will I know whether the sensation is less or not? We ask the patient to close the eye, we are touching the cheek with the cotton. He has to count whenever there is a touch. So it can be on this cheek or this cheek. So the affected side, you see, he starts missing the count. Okay, so this is the way we will judge whether the sensation is good or not. Then what else you are going to get? Just you saw in that clinical slide, I had gone inside. This is called inophthalmos. So in honors you had learned was apparent inophthalmos. This is true inophthalmos. And of course there can be diplopia, right? Now why are you getting a diplopia? Diplopia will happen because of few reasons, isn't it? So first important reason is there is edema and hemorrhage can be one cause which is restricting the motility. Second, it could be just entrapment of the muscle at the fracture site. So which muscles can be entrapped on the floor fracture? The inferior ones, inferior rectus, inferior oblique. So entrapment of muscle, which muscle? Common sense, it can be inferior rectus or inferior oblique. Or it could be actual injury, direct muscle injury. So any of these things will lead to diplopia. Any other feature we want to mention here? Which is the weakest wall of the orbit? It is the medial, so that can always be affected. If medial wall is affected, the sinuses will open. What are you going to get is subcutaneous emphysema. So what we are going to get is a subcutaneous emphysema. Okay, but only please note it down, if medial wall is affected, you are going to get this. And due to the pull of the muscle, very important point, it can actually incite a oculocardiac reflex. Now when you say oculocardiac reflex, we will be discussing in squint chapter also how the pull on the muscle can lead to bradycardia and sometimes cardiac arrest through the vagus nerve. Right? So the afferent is from the trigeminal and efferent from the vagus. This is your oculocardiac reflex. So this can also happen in blowout fractures if there is a pull in the muscle. So it can incite an oculocardiac reflex. So that becomes very dangerous, of course. Right, so these are the features. We come to investigation. Of course, we can go CT scan, or you can even do an X-ray PNS view can help us to see the floor. So whatever you do, either of this, what you get, let's understand that. We are getting, make this diagram. This is the floor fracture. Below this is what? Maxillary sinus. The sinus is filled with air, so it will be black. Right? So against this black background, I am getting an opacity like this. This is what is called, repeated question of exam, teardrop sign. So this is what is teardrop sign. So what is teardrop sign? Which is an opacity against the black background of maxillary sinus. Here it is. So this is a blowout fracture within ophthalmos. There is a chymosis, right? And this is what is teardrop sign we're talking about.
Question 17. Ectopia lentis is seen in? Here are the options. A. Homocystinuria. B. Refsum's disease. C. Wilson's disease. D. Sarcoidosis. And the correct option is A. Homocystinuria. Here is the explanation.
So the next thing they started asking was which direction ectopia lentis occurs. So this is my age-old, very famous method, how to remember the directions. We make M of Marfan's. And over the head of the Marfan, we will put an arrow. So what direction is this? It is supero and away from the nose is temporal. So it is a supero-temporal ectopia lentis. Okay, so this is supero-temporal ectopia lentis. This is what you get in Marfan's. And then in the same diagram, we can make dotted line and put an arrow like this. So just the opposite, down, infero and nasal, not temporal but nasal is H, right here H, homocystinuria. Okay, it is infero-nasal, correct? Then we talk about, and there was one question where inferior and nasal both are given separately. Definitely we will first mark inferior. And they're coming to veal marchesi, it is inferior subluxation. And along with that, what you get is small spherical lens, which is called microspherophakia. Small and spherical lenses, microspherophakia. Right? Ehlers-Danlos, no direction mentioned. We simply learn ectopia lentis. And another very important feature here is blue sclera. This is also a Q. Okay, so blue sclera. What is blue sclera? Sclera is blue in color? No. So it's a very thin sclera so that the underlying uveal tissue is visible. That is called blue sclera. We'll talk about its causes in sclera chapter. As of now, we will just learn this as blue sclera.
Question 18. A 23-year-old male presents to the clinic for evaluation of his decreased vision. He complains of ocular pain and photophobia. On examination, his eyes are red. The eyelashes are turned inward and the eyelids are scarred. After the extensive workup, a diagnosis of trachoma is made. Which of the following is the drug of choice for trachoma? Here are the options. A. Erythromycin, B. Ganciclovir, C. Clindamycin, D. Azithromycin. And the correct option is D. Azithromycin. Here is the explanation.
Of course, SAFE strategy, we have already done that. It was asked even this year. SAFE is very important. NSET exam, NEET, PG, everywhere SAFE strategy is asked. It's such a simple question. Right? So what is SAFE strategy? SAFE strategy is the WHO program to control trachoma in a community. We have written that in the conjunctiva chapter. So it's a WHO program to control trachoma in an area or community. And we all should quickly know this. S stands for surgery, with surgery, trichiasis surgery. Okay? If trichiasis is not given in the option and it's mentioned entropion, you can answer that too. But first preferably answered should be trichiasis. Okay? Then A and stands for antibiotics. Which antibiotics? Again they can ask you. Either I can go for oral azithromycin or I can go for topical tetracycline. Right? So oral azithromycin or topical tetracycline. Okay. You all should know tetracycline is only available in ointment form. What is the percentage we give? Has been exam question. Q lagao, it is 1% ointment, right? Can you imagine 1% ointment all the time inside the eye? Compliance is not good, we will forget it, we will not comfortable. So what should be the choice among the two antibiotics? We should answer, it should be oral azithro. It's more effective also and it's easier to use. You just have to eat 2 tablets and you are over with the schedule. Okay? So compliance is much better. What is the dose of azithro? We all know it is 1 gram in adults, right? And 20 milligrams per kg in children. Okay. So this is a quick repetition because SAFE has been asked almost every year. So we will give that respect to this topic, that we will repeat it. Okay. Then we talk about next is what is facial hygiene. Everybody knows F is facial hygiene and E is environmental cleanliness, right?
Question 19. According to the WHO classification of xerophthalmia, X2 is. Here are the options. A. Night blindness. B. Conjunctival xerosis. C. Bitot spots. D. Corneal xerosis. And the correct option is D. Corneal xerosis. Here is the explanation.
So write down what is xerophthalmia. It is nothing but spectrum of ocular disease due to vitamin A deficiency. I hope you have written. It is spectrum of ocular disease due to vitamin A deficiency. Okay. So once we know this, what are the clinical features? You can learn very nicely by WHO grading of xerophthalmia. Right? So what is the WHO grading of xerophthalmia? We can divide as XN. X stands for xerophthalmia. So XN is night blindness. which is called nyctalopia. Night blindness is nyctalopia. Then X1AB. A, it is conjunctival drying or xerosis. Severe drying is called xerosis. It's a severe drying which is called xerosis. And when it is too severe, the patch of dry spot that you see near the limbus is called B for B, Bitot spot. Okay? Okay, we come to X2. Now the cornea starts drying, so there is a corneal xerosis. Everybody knows now vitamin A is a very important component for health of epithelial lining and also very important component of rods. So initially what will happen is the function of rods are affected, you get night blindness, and then next what you're getting is conjunctival xerosis, then corneal xerosis. Then again 3 is divided as A and B. This keratomalacia in less than 1/3 of cornea, involving less than 1/3 of cornea is A, and keratomalacia involving more than 1/3 is B. What is keratomalacia? Liquefactive necrosis of the cornea. Okay, so it is liquefactive necrosis of the cornea. Please remember that. And then comes your excess where there is a corneal scarring, right? So corneal scarring. And then lastly, XF is xerophthalmic fundus. How does it look like? So the xerophthalmic fundus means there are white spots on the fundus. So a white spotted fundus is called xerophthalmic fundus. Right? Okay. So when it affects the fundus, definitely we see that there is decreased amplitude in electroretinogram. There is also decreased amplitude in the electroretinogram. We'll talk about electroretinogram in retina chapter of ERG.
Question 20. Keratometry is used to assess. Here are the options. A. Corneal sensation. B. Corneal endothelium. C. Corneal thickness. D. Curvature of cornea. And the correct option is D. Curvature of cornea. Here is the explanation.
What are the investigations related to the cornea? So give the heading investigations related to cornea. First you will learn is keratometry. I'll show you the slide later. Write down keratometry. So keratometry is measuring the central optic zone, right? Curvature of cornea, both vertical and horizontal, K1 and K2. But this is only for the central optical zone of 3 millimeters.
Before you go, make sure to set a reminder for a quick mock test on PSM. If you have found the video helpful and learned something new today, don't forget to like it and subscribe to the channel. See you then.